Thank you all so much for joining today's Public Health Discovery Seminar Series. My name is Cassietta Trewick. I go by Cassie. I am one of the admission counselors here at the City of Scott Weatherhead School of Public Health and Tropical Medicine at Tulane University. And today I have the pleasure of introducing our Health Policy Management PhD candidate, Debra Winberg, who is presenting today's seminar series on negotiating health, navigating the Inflation Reduction Act impact on Louisiana Medicare and diabetes drugs. And so, Debra, I'm going to let you take it away.
Perfect. Hi, everyone. Really nice to get to speak with you all today. So yeah, today I'm going to be talking a little bit about the Inflation Reduction Act. I've been doing some research on this for the last 2-ish years at this point. So I'm really excited today to get to talk to you about this. So first off, before I begin, just a little bit about me. So I'm a 4th-year PhD candidate at Tulane right now. I'm in the Health Policy and Management Department within the School of Public Health. And most of my research is really focused on diabetes and chronic disease research. But in addition to that, I have a lot of experience in health technology assessment, which if you are all not familiar with that, that's kind of how other countries do a lot of negotiating. It's based on understanding the cost effectiveness of drugs and then negotiating prices. I have a lot of experiences with the pharmaceutical industry. I've worked for several pharmaceutical companies, and I've done a lot of research on drug pricing. So just today, I'm going to go through a little bit of background about Medicare spending, drug spending, and the IRA. Go into little methods involved in a research project I'm doing, go through the results of this project, which are really exciting, have a discussion about it, and then open up to a Q&A. Just a quick disclaimer before I begin. Obviously, the political climate this week has shifted a little bit since I did a lot of this research. So all of my projections are based off of what we assumed about the Inflation Reduction Act before Tuesday. That being said, it's still really important, regardless of anything that happens in politics, to really show really good evidence to try to advocate for policies. So just keep that in mind as we go through. So a little bit of background for those of you who are less familiar with these topics. So I have here a timeline of key US drug policies and Medicare legislation. So in 1965, there's the Medicare and Medicaid Act, and this is really what established Medicare and Medicaid for the first time. To note, this excluded prescription drugs. In 1983, shifting over to the drugs a little bit, there was the Orphan Drug Act, and this encouraged development for rare diseases by incentivizing innovation. And this is the key part I really want to focus here on, is this incentivizing innovation. This is something the US government has done a lot of in the past 40 years. Right after that, in 1984, there's the Hatch-Waxman Act. If you're at all interested in drug pricing, highly recommend reading more about the Hatch-Waxman Act. And this really created the generic drug market by allowing faster approval of generic drugs, coupled with patent extensions to really protect the pharmaceutical companies with that innovation piece. In 1997, there's the FDA Modernization Act, and this really streamlined the drug approval processes. And although this is not super relevant for this project, what it did also do, just I think it's a fun fact, is it allowed pharmaceutical companies to advertise directly to consumers. So when you all are watching TV and you see something promoting Ozempic with a catchy little tune or jingle, that wasn't legal until 1997. And there's actually only 2 countries in the world that can do that, is the US and New Zealand. So just a bit of a fun fact. In 2003, there's this really important Medicare Prescription Drug Improvement and Modernization Act. We usually just call it the Medicare Modernization Act. And this added Medicare Part D. Part D is really what introduced drug reimbursement to Medicare. So again, 1965, there's no prescription drugs. In 2003, prescription drugs were reimbursed by Medicare. And then this also, however, prevented Medicare from negotiating drug prices. So in 2003, the government was not allowed to actually interfere in drug pricing. So we weren't allowed to do a lot of the pricing strategies like negotiating or tendering or things like that for the public, so Medicare, Medicaid, as of 2003. In 2010, we all know the ACA was passed. This closed the donut hole in Medicare Part D. Not super relevant for this talk, but again, just important legislation. And then what we're focused on today is the 2022 Inflation Reduction Act. This had major revisions to Medicare drug policy. I'll go in more detail into this in a few minutes, but the IRA did a lot of stuff to try to combat inflation. It had a lot of climate change involved in it, climate change policies, a lot of drug policies, a lot of stuff in there, but this Medicare negotiation was a big piece of it. So switching over a little bit, just level setting what we all know about drugs and drug costs. Drug costs are really expensive and they're rising. This shouldn't come as a shock to anyone. Between 2009 and 2018, drug prices in the US actually increased at an annual rate of 4.4%. At the same time, median out-of-pocket, so if you see OOP on my slides, that's out-of-pocket costs. these increased by 9.6% per year. So on one hand, you're having drug prices just increasing, and then you're also having out-of-pocket costs increasing at an even higher rate. And this means that in 2021, the US health system actually spent over $600 billion on prescription drugs. And within a 5-year period, that was a 16% increase. So drug prices are increasing, and they're increasing very fast. Because of this, many Americans cannot afford medications. About 82% of adults believe the cost of prescription drugs is unreasonable, and about a third of adults cannot afford their prescriptions because of the costs. High drug costs have significant consequences. As I said, about a third of people can't afford them, and because of that, they're not taking their medication as prescribed. If you're not taking your medication as prescribed, you have worse health outcomes. So for example, say you're not taking your diabetes medication, you're not controlling your glucose, that's going to mean that you have worse health outcomes, like maybe you develop chronic kidney disease. Having these worse health outcomes usually increases healthcare resource utilization and can lead to early mortality as well. So at the same time as we have all these really increasing drug costs, we also have Medicare becoming a more major payer for prescription drugs. So here in this graph, the blue bar represents the percentage of drug spending in 2005, the green is in 2006, and the gray is in 2021. So I really want to focus on this piece on the left here with Medicare. Between 2005 and 2021, Medicare ended up having an additional 30% share of prescription drug costs. And this is pretty much even double since 2006. So really high increase in Medicare. We need to do something based on this to really help combat Medicare costs because it's a third of the drug costs out there. And that's compared to, we can see on these other ones, Medicaid's actually gone down a little bit over time. Private insurance has gone down a little bit, but not as much. And while out-of-pocket costs, we can see here have decreased, and that's really because of a lot of these other policies I talked about. If drug costs are continuing to increase while the share of out-of-pocket costs decreases, the actual number that patients are spending still increases. So there have been many programs put in place to combat the rising drug prices. So some of these, for example, include pricing transparency, affordability review boards, price capping, and then some more innovative price strategies such as value-based pricing, which is becoming especially common in the oncology space. And there are all some successes when we look at these policies. So for example, indication-based pricing was shown to lower prices and increase the market penetration of the immunotherapy drugs. And many commercial insurers have implemented successful small-scale programs to decrease out-of-pocket costs. So just an example of this, I'm working on another project right now at Tulane in my department, looking at the impact of a $0 copay program through one private insurance plan. And we did find that that plan increased medication adherence and decreased blood glucose levels. So there are successes. That being said, there's a lot of challenges. And primarily, going back to that timeline, Medicare historically could not negotiate prices like international agencies or private insurers, and they can't do a lot of these innovative pricing strategies because of that 2003 law. So because of that, Medicare's had these high costs without a lot of ways to combat them. So in 2022, the Inflation Reduction Act was passed to help try to combat these drug prices. So there's 4 primary parts to this. I'm not going to go into detail about all of them, but just so we all are aware. There was a $35 insulin cap, which I think is one of the ones we've heard a lot about in the news. There's a yearly cap on out-of-pocket drugs for Medicare beneficiaries. So that Medicare beneficiaries would not have to spend more than $2,000 out of pocket a month on drugs. Sorry, $2,000 a year, not month, a year. The part we're focused on is Medicare drug price negotiations. And this meant that Medicare would be able to negotiate directly with drug manufacturers to lower the price of some of the costliest single source brand name drugs. The inflation rebates, which is when we get the IRA's name. And this requires drug companies that raise their prices faster than the rate of inflation to pay Medicare a rebate. And then some of the other changes help with access to biosimilars. So as I said, today we're really focused on the drug price negotiations. So these drug negotiations were announced in 2002 when the IRA was released, but it was really a slow ramp up. And I think that's one of the things with policy. And if anyone here is doing policy research or interested in policy research, is we hear that these things come into place, but then it takes time to actually be implemented. So this was announced in 2022, but these new prices aren't taking effect until 2026. And I'll explain why this is more relevant for this project in a minute. But just to go through this, in 2023, the 10 drugs were selected for the first round of negotiations. The negotiations between the health department and drug manufacturers lasted from about October 2023 to a few months ago in the summer. The maximum fair prices, which were these negotiated prices, so you'll hear me use the term MFP or maximum fair prices, these were published in September. And then these new prices were going to take effect in 2026. Then the bottom here, just the second round. So again, this is going to happen about every year. And we're really looking forward in February, if this stays in place, to see what these new drugs will be. To note, Ozempic is actually probably one of those drugs being negotiated this year. So just a bit of interesting there. So these are the first 10 drugs that were published in 2023. And a few things to note here is one, there's a lot of different manufacturers here. This is not targeting one pharmaceutical company. It is a large mix of them. And these are really for chronic diseases for the most part. So drugs that are expensive and people are going to be on for a very long time. So we have multiple diabetes drugs on here, some for heart failure, blood thinners, only really one cancer drug for leukemia and lymphoma. But looking at this column on the right, we can really just see how expensive these drugs are. Between June 2022 and May 2023, so about a year time period, these drugs cost billions and billions of dollars. Trillion if I'm reading my zeros right. So they're very expensive. Sorry, no, that is billion. I'm really bad at zeros, guys. You can be really good at statistics on computers and not be great at reading zeros. So there is a little bit of initial data on our IRA impacts, and they seem fairly positive, but there's still some pushback. Some of these potential costs that are in the literature include there is an idea that they will decrease costs. If they decrease costs, CMS spending will decrease, out-of-pocket costs will decrease, and there's some idea that insurance premiums will decrease, but we don't really know. There are other spillover effects, including the introduction of competitive biosimilars and promoting consistent pricing. An overall benefit means that this will just improve access to drugs by enhancing affordability. There are, though, some potential negatives. No policy is only going to be positive. The biggest one that you'll read about in the news, or in more the news than the literature, but pharma companies have been really good at pushing this, is that it might impede innovation. If there's reduced financial incentives, it's going to be a lot harder to invest in innovation. And as you can see from the timeline I showed you earlier, a lot of US policy has been very, very focused on innovation. So this is a big concern. The other one is that there might be less drug access. This is not as commonly discussed as a challenge or a negative, but it is there as a potential issue, is that companies may prioritize broader indications for higher financial return. So this means that like you might pick trying to invest in drugs like for diabetes or hypertension and not something like rare cancers or rare immuno diseases. So you're going to have a lot of patients who can't get better treatment because no one wants to invest there. There's also some idea that it will decrease the number of drugs on formularies, and some patients do better on some drugs. So if that drug's not on a formulary, that could lead to issues. There also might increase prices for other patients. There's an idea that there will be a cost shift to non-Medicare plans, which will increase the cost for non-Medicare patients. And just with this landscape in mind of potential benefits and negatives, pharma companies have sued the US government. They were unsuccessful, really because of that impeding innovation piece. But really, this just shows we really need to do more research on the IRA's potential benefits and really look at geographic region specific data to try to show that this is a beneficial policy. And again, this is the problem with policy research. You a lot of times need to prove that a policy might be successful, but we're not going to have data on this for years and years to come. Even if 2026 is when drug prices come into effect, we're not going to necessarily know the cost savings for at least a year or two, and we won't see the long-term health benefits for multiple years as well. So you have all these people kind of speculating on the negatives and the positives, but there is no clear evidence yet. So that's where my project comes into place, is that this project really aims to model the potential effects of the IRA on diabetes drug spending in Louisiana through looking at Medicare total cost spending and patient out-of-pocket costs. For those of you a little less familiar with cost effectiveness research, which this is not, but then some other policy research, we do try to look at real world data that we get after the fact, but these types of modeling projects are also fairly common as a way to try to predict what might happen. So I'm not going to talk too much about the methods. I don't think they're the most interesting part of this project, and some of it's a little nitty gritty, but I am going to talk a little bit about how we did some forecasting and modeling based on 2016 to 2020 data and the published maximum fair prices. So the data we use for this project is CMS Medicare files from 2015 to 2020. The Health Policy Management Department has Medicare and Medicaid claims data. So what this means is that for those of you not familiar with claims data, we have the data from every visit for Medicare beneficiaries and inpatient, outpatient, and pharmaceutical claims. So we can see how much Medicare paid. We can see what patients paid. We can see what disease or condition they went into the hospital for, what procedure they got done. those sorts of things. So you can really get a sense of the health outcomes and the costs associated with a visit. We also have this thing called the chronic conditions file for each beneficiary, which lists, let me a list of, I think about, I should know this off my top of my head, and I don't. I think it's about 20 different conditions that people have. So diabetes is one of them. Then Part D event files, and again, Part D is just the drug claims. So our cohort was specifically diabetes patients based on this Medicare chronic conditions file. And to note, we looked at patients with type 2 diabetes, type 1 diabetes, gestational diabetes, and secondary diabetes, and a few others. This is because the chronic conditions file has diabetes listed as one general disorder with all of these. You can get in claims data actually looking at if it's type 2 or type 1 when you look at the actual claims, but for this project, we did this just to keep it very broad because lots of people can be on these medications for different types of diabetes. And then we also just looked at total Medicare beneficiaries per year. So for our model, we kind of have this in 3 main sections when we were building our model. And just to note, we did this in Excel. So for those of you just getting into public health research, we talk a lot about using really complex methods in R or Stata or SAS or Python, but you can actually do a lot of really great research in Excel just by doing basic modeling. So what we did first is we had some general calculations from the initial data. So we used the Medicare data from 2016 to 2021 for the Louisiana beneficiaries of diabetes. And using this, we calculated the annual growth rate of diabetes, so the percentage of patients with diabetes in each year, the rates of usage for the IRA listed drugs and also non-IRA listed drugs. So we looked at this is specifically diabetes drugs. We didn't include insulin in this. This was just the oral medications and some injectables, but not insulin. And that's because there is the $35 insulin cap. So that's a different policy than just the maximum fair pricing. And then we looked at the average cost for these drugs, looking at the total cost per patient and the out-of-pocket costs. So then to get the base case, what we did. So the base case is what would happen if there was no IRA policy. As I said, the IRA policy took place in 2026 to 23. It started in 2026. So we needed to first get the cost from 2021 to 2025 because we don't have that data in our department yet. We're getting a little bit more, but we didn't have it when we did this project. So we predicted the patient costs and total costs for 2021 to 2025 based on the average cost of the drug and the number of people on the drugs. We did some modeling for this, just really basic forecasting. And then we continued the forecast up through 2030 for this base case. So assuming that there was no IRA imposed MFPs. So then that's our base case. We have this general 2021 to 2025 predictions and 2026 through 2030 predictions. So then we had another kind of row on Excel where we're looking at the IRA policy scenario. Again, it started in 2026. So we have the same numbers from the 2021 to 2025. Then using the drug costs that were published in September, we adjusted for inflation every year and used these prices and just put these into the model. The other thing we changed with this forecasting is that we assumed an additional 5% of patients switch from non-IRA to IRA drugs each year. So that's really just the basic bit of the model. The 2 main points I want to show are the costs came from the published prices and this transition probability piece where we assumed a 5% switch every year. I know this kind of does sound kind of broad and this is just data and what is all the modeling in Excel, but this is a really common exercise when you're forecasting and putting in different numbers when you're trying to see what might happen in the future. So I just want to highlight a few of the model inputs. So this is the actual published Medicare data we had from 2016 to 2021. So this is a lot of numbers, so just highlighting a few. In 2016, 17% of Medicare Louisiana beneficiaries had diabetes. And in 2020, 15% did. This number really, between 17 and 15% over all these 5 years, that is a fairly steady rate. But our 2020 data might be a little underestimated because less people were interacting with the health system during COVID. We're also expecting this number to grow over time just because diabetes is increasing. So just keep in mind that I'll get into this as a limitation later, but just wanted to highlight this. The other thing I really want to highlight is the average cost of the drugs per year. So on the second to bottom row here, the average cost for non-IRA drugs per patient is about $1,300 per year. For the IRA drugs, so we have 3 diabetes drugs, Januvia, Jardiance, and Farxiga. They're about $4,000 each. So these IRA drugs are about quadruple the price. The IRA drugs are about quadruple the price of the non-IRA drugs, and that's really why this is a concern and why they're on the negotiation list. So going into my results a little bit, so what we have here, the gray bar is the price of the diabetes drug if there was no IRA. And the black price is the price with the IRA into play. So the gray bar is the Louisiana specific prices we calculated. The black bar is nation specific MFPs. So in Louisiana, Jardiance is going to decrease by about 66%, we estimate. Januvia by about 78%, we estimate, and Farxiga by 66%, we estimate. This is huge. Januvia is going to decrease by about 80% in cost, and like that's insanely large. If you guys are reading anything about the IRA, these estimates are a little higher than a lot of the nationwide estimates that are being given. And the reason for that is that drugs just do cost differently based on where you are. And clearly this policy is going to have a really large impact in Louisiana. So this is our main results here. So I'm going to explain this graph for a second, but so on the bottom line / 2 lines where it splits, we have the IRA drugs with no IRA policy in place and with the IRA policy in place. And on the top, we have the non-IRA drugs with the policy in place and no policy in place. And this is total Medicare beneficiary population average populations over time. So that's why you're seeing like numbers in the millions versus before it was like 150, because this is total Medicare costs in that year. So highlighting a few things here, again, the non-IRA drugs do still cost more than the IRA drugs when you're looking at overall spending because it's just a larger category of drugs. And there's a lot more people on these drugs. That being said, in 2026, where we see that decrease in cost in IRA drugs because of the IRA, we see a significant immediate decrease in total Medicare costs, like a pretty significant drop when you look at that. This does slowly increase over time, and that's because of a mix of inflation and just we have more patients switching onto IRA drugs. And the switching to IRA drugs is good because when you're switching to these newer drugs, they tend to be a little more effective. So you might have better health outcomes, and then you can have more cost savings over time. So even if you look in 2030, although that gap is not as large as it was in 2026, we still estimated that Medicare would save approximately $57 million in 2030. When we look at the non-IRA drugs at the top, what we were not necessarily expecting was a decrease in costs for non-IRA drugs too. So this is about the same amount as the IRA drugs. And again, this is because of the transition probability we put in of people switching from non-IRA drugs to IRA drugs. We only put a 5% transition probability in to be kind of conservative. So the potential for cost savings is even greater than what our model shows. And this is without considering health outcomes and the cost you're going to spend on complications as well. So overall, just looking at this graph, we can see significant cost savings over time, but there's a few really small interesting nuances that I just touched on. So overall, we found that the IRA may lead to CMS and patient cost savings. Over the first 5 years of implementation, our model showed about a $400 million savings for Louisiana Medicare overall. And then we found some out-of-pocket cost savings as well. So between 2026 and 2030, the greatest decrease in average monthly out-of-pocket costs is going to be in Januvia, which decreases from about $25.50 to $6.50 per month. Then the average monthly cost for Jardiance and Farxiga are similar, and they drop from about $32.83 per month to $16.86 per month in 2022 to $12. So you see about savings by about 50%, which again, I know I showed you on that first chart where you were looking at like the 66% decrease, but I think when you're doing policy research, sometimes it's really important to like show that actual dollar amount for savings that patients have. And I mean, $25 to $6 is significant. So overall, patients will save about $1,000 over the 5 years because of this policy. So overall, just summarizing what we found in these results, is the IRA will lead to significant savings for CMS and reduce out-of-pocket spending for patients. The 3 IRA diabetic medications are prescribed to a very small proportion of patients, but they require a disproportionately high budget. So even moderate IRA discounts can lead to significant cost reductions, and we found that it is a little more than significant discounts. And given Louisiana's higher than average drug costs, savings in the state may surpass national averages. So what does this all mean? This is one of those things where policy is a ever-changing field. And based on what's happened in the past, CMS's budget either has 2 things it does. It either increases or it stays stagnant. We couldn't really predict which one it could be, so have scenarios for both. If it increases, if CMS's budget increases at the same time as the IRA policy, they'll be able to expand to provide more innovative drugs to a greater proportion of the population because they have to spend less money on these diabetes drugs. That being said, even if the CMS budget remains static, there still be cost savings from the decreased cost of these diabetes drugs. And then patients can still have better adherence because of lower cost barriers. So either way, it kind of depends for this, if it increases or stays stagnant, how much more innovative drugs CMS will be able to give people. But either way, it will be cost saving. There is some talk now that CMS's budget may decrease, which is not a scenario on this slide. But obviously, if a budget decreases, cost savings are really, really important to make sure that even the same number of people can get these drugs. Overall, though, regardless of any of this, the population health will benefit from improvements in adherence and increased access to effective medications due to lower costs. So really, there are potential benefits for Medicare beneficiaries because of all the stuff I showed you on the slide before and the data we showed, but it's still a little bit unclear what the exact benefit might be. And this is where I'm telling you guys that policy research is great, but when you're modeling what will happen in the future, it is a little bit of guesswork based on educated guesswork, but guesswork based on the literature. So the limitations we really have in predicting a very clear outcome is that there's a lack of clear out-of-pocket cost calculations when you're looking at this policy. So we're assuming that patients have the same cost reduction as CMS and they'll benefit from the policy, but we don't actually know how this will impact patients. And we also didn't model price elasticity. So those of you not familiar with price elasticity, this means that patients or people in general, depending on how much a price changes, their behavior changes differently for different products. So say if you're trying to buy a hamburger, you may be like, I'm not at all buying a hamburger when it increases by $3. But if you're going to buy your diabetes medication, if it increases by $3. So that's this idea of price elasticity, and we don't have that number for this project. That being said, research has shown that lower out-of-pocket costs are associated with anti-diabetic agents. When you lower out-of-pocket costs for anti-diabetic agents, it does increase medication adherence. There is a lot of literature proving this. So we're assuming that by improving anti-diabetic medication adherence, because those costs decrease, Medicare members can achieve improved glycemic control. If they improve glycemic control, then diabetes-related complications will decrease and healthcare resource utilization will decrease. So again, this is what we're assuming. We don't have legit data to show this, but based on the data we do have and what the literature shows, we believe that out-of-pocket costs will decrease, adherence will increase, glycemic control will increase, complications will go down. This does not always happen. We're really assuming it will, but again, we can't really tell the future, but the evidence is pretty positive. The other part of this that we didn't really look into is that negotiations will be combined with other IRA aspects, which will compound results. So again, this $35 insulin cap will really further improve diabetes care because a lot of diabetics are on insulin and other medications. And then with higher discounts and lower out-of-pocket costs, members can buy more drugs with their $2,000 price cap. So although there was this $2,000 price cap, it may not have included as many medications beforehand, but now it will be able to because prices will decrease. And this is really essential specifically for diabetes because it's associated with many comorbidities such as hypertension and kidney disease. So being able to buy more drugs at cheaper costs is really great for patients with multimorbidities like diabetes and CKD. And the other thing we did not investigate is pharmacy benefit managers. If you're not familiar with pharmacy benefit managers or PBMs, they're kind of the middleman of this whole situation. And why this matters is that currently CMS is really not actually paying for list prices, although they're not negotiating because of rebates and some other policies. So we weren't able to really predict how rebates would change or how they would impact the costs, and we didn't really account for these middlemen in our analysis. So because of this, the true savings for the patient and plan may be deceptive because of this opaque nature. We just don't really know. We didn't include this in the analysis. So really just PBMs are a little complicated, but just really in summary, costs may not be as reduced as this analysis makes it seem. They just might be shifted from one place to another. So our project had a few limitations I just want to highlight. Our projections included 2020 data, and changes in healthcare patterns due to COVID have impacted drug utilization and rates of diabetes diagnosis. We assume, if anything, this would underestimate our results, which means that would actually have a larger impact. It's also underestimated because rates of diabetes are expected to continue significantly increasing over the next several years. The other thing we did is we kind of just incorporated non-IRA drugs into like one non-IRA lump sum, but this isn't really the case. Patients take different numbers of drugs. So because of that, if you're looking at a per patient level, our estimates may have significant variability for each patient. And this is only Louisiana. The purpose of this project is to look at Louisiana Medicare, but these results may not be generalizable nationally, just to note. So in conclusion, we assume that in Louisiana, the IRA is going to decrease drug spending for Medicare and patients. This will increase Medicare medication adherence and medication access for patients, which will improve health and decrease healthcare utilization and mortality. If you guys have any more, I'm going to obviously stay for the rest of the seminar to answer questions, but here's my email if anyone has any further questions they'd like to contact me about. Thank you. Happy to have a discussion about this now.
Thank you so much, Debra, for that wonderful seminar. And so, yes, if you have any questions, please drop it in the Q&A chat. So if you don't have any questions, again, thank you all so much for joining today's Public Health Discovery Seminar Series. Thank you so much, Debra, for presenting your seminar. Oh, we do have a question in chat. Thank you for the nice presentation. I have a question on how to convince policymakers to adapt a new drug into the clinical practice.
Yeah, so that is a little, I'm just gonna stop my share. I can share my screens, but this way with my multiple screens, I can look at you guys at least the screen a little bit. So yeah, that is a little outside what we did on this project, but generally to convince drug makers to adopt a new drug in a clinical practice, it's all based on that data. What is the RCT showing? Do we see an actual effectiveness? And if we can show that the drug's effective, we can get it approved by the FDA. Now, getting a drug approved by the FDA does not necessarily mean that it's going to actually be adopted into clinical practice for several reasons. Some of that includes pricing. Some of it includes getting physicians to actually prescribe people drugs, educating patients and physicians on the drugs. So the few things we can do here to try to increase access to a drug and put it into clinical practice earlier is that pricing viewpoint. If we can decrease costs for patients, we can really help them want to take it. And there's a lot of innovative ways we're doing that. For example, maybe a drug is very expensive and we think it will be successful, but we don't really know. You can put like a outcome-based pricing measure into that, and things like that. The other thing that we're trying to do is use real world evidence and patient reported outcomes to try to prove that this drug can have value for patients.
The next question that we have is, thank you for your presentation. Please, I would like to know if you consider other confounding factors affecting their costs.
So medication costs here, the PBMs are the confounding factor. We were not looking into that in this project just because it's kind of its own general research and it's a very opaque process that we don't really have insight to. We didn't do any regressions here, so there's like no confounding factors in our project, but the cost is pretty much here. There is no other confounding factor except for the PBMs here because they were negotiated. So you get rid of all these external factors that could really impact the cost.
All right, does anybody else have any more questions? Okay, says thank you so much for an informative presentation. I wonder in the middle of your search, if you found any noticeable difference in age regarding prescription drugs.
We were not looking at age for this. We were just looking at general cost per patient. Obviously, age would also impact how many other drugs you might be on, the comorbidities you have. But we didn't specifically look at the difference in drug uptake per age in this specific study.
Next question is, what is the comparative cost analysis saying across states?
Everyone is saying across the country that this policy will decrease drug spending. It will lead to cost savings for Medicare, probably help patients save money. It is overall leading to a lot of cost savings. The numbers are just a tad bit higher in Louisiana than nationwide, but nationwide, this policy is going to lead to cost savings. Again, it's all based on modeling right now, but it does have a positive nationwide impact. I don't have any data right now on like which states it will impact more than others, but it overall will lead to cost savings.
Are there any more questions?
And I can put my email in the chat if anyone wants to send me any further questions. Price negotiations is like one of my favorite things to talk about, so happy to continue the conversation if anyone wants to.
Next question we have is, any difficulties when you were collecting or generating data?
So we didn't collect any data. This is all secondary data research based on Medicare claims data that we have. We didn't really have any issues generating the data itself. It's pretty straightforward to calculate costs with Medicare claims data. The only issue, again, we did have were some of those limitations surrounding, we think 2020's data is a little bit off. And we don't know what's going to happen. Like, this is all a modeling exercise. So we did do, I didn't put the slides up there, but we did do a few things, like instead of a 5% transition probability, if we do a 1% or a 15%, what would the difference cost savings be? There's still cost savings, it just differs per the amount. But yeah, the biggest issue we had in this project wasn't necessarily collecting or generating data, but just finding ways to handle the just lack of information about what will happen in the future. And there's a lot of standard modeling techniques you can do to try to account for this, that like doing different, putting in different numbers and seeing how it changes, which we did do.
This person said, this is not a question, but they said, thank you, and I will reach out to you via email. Well done. And just to reiterate, Deborah's email is in the chat, so definitely copy and paste that if you have any questions that you feel like you don't want to answer in this seminar series. We totally understand, so definitely utilize her email. Another comment, not a question. Thank you so much, and such a fantastic, fascinating research. All right, if there aren't any more questions for Debra, I'm going to give you back 20 minutes of your time. Again, thank you all so much for joining today's Public Health Discovery Seminar Series. Thank you so much, Debra, for presenting. We really appreciate it. Please go on our YouTube playlist for our Public Health Discovery Seminar Series. You will get to see Debra's as well as other presenters from this Public Health Discovery Seminar Series. And so you will receive that in an email with the link, but I will also drop it in the chat for you, just so you can see that Public Health playlist. Oh, wait, we got another Q&A. So someone asked, will the cost of drugs differ with age?
Your total drug costs will differ with age, because usually you end up having more comorbidities as you're older, which means that you're going to just have say you're on 5 prescriptions versus 1, you're going to have personal total drug costs increase. But for the sake of these IRA drugs, no, the price is standardized across patients. And that is, again, one of the benefits of these negotiated prices, is that it is the same across the board for everybody.
Okay. I think that is our last question. Again, please feel free to email Debra with any of your questions regarding today's seminar series, or if you want more information about her research. I'm pretty sure she'll gladly answer those questions since she provided the email. But again, thank you all so much, and you all have a wonderful day.